So here we go. So this is the second lecture. This is going to focus on the AC, joint mechanics. You could tell that the AC joint, where it meets the acromion and the clavicle, really doesn't have a lot of convexity or concavity, generally flat on each of those aspects. So for that reason, it's considered a plane joint. There's not really any convex-concave rules that would apply to that. And as you could tell from the joint and the movement, there really isn't much movement that occurs at that joint. So it's going to be minimal movement. It is primarily a stability joint, so the primary functions are going to be to allow the humerus to go through multiple motions appropriately, and as the humerus goes through motions, the AC joint is going to help, because it's attached to the scapula, to position that glenoid appropriately. It's almost like a guide for the glenoid as it moves throughout. And then lastly, as a shock absorber, it's going to help dissipate some of the forces that may occur through the upper extremity with trauma or other activities and movements. There are several structures that support this. Primarily, as we look here at you could see the coracoclavicular ligaments, so they're connecting the clavicle here to the coracoid process, two portions, the trapezoid here and the conoid here. So the conoid, as you could tell, running from superior to inferior, is going to help to limit any inferior translation. So if that scapula or that acromion wants to get further away from the clavicle, it's going to stretch. It's going to prevent it from going further down this way, even though the acromion is over here. And then the trapezoid. Now, do you notice how there's a little bit of a shape? This is only a two-dimensional image, but really there's going to be a lot of HP direction to this ligamentous structure. So if I could spin this around, you would see it's actually resisting a lot of the posterior translation. So if the clavicle is stationary right there, it's going to prevent that acromion from going further posterior. And that's a quick summary of that. For the kinematics at the AC joint, does not move as much as the glenohumeral scapulothoracic joint. The one thing you could do, they kind of picture this like a book. So if you just take a book and just kind of hold it at its axis point right there, you could play around and practice the different motions. The one thing I'll point out is that the AC joint is connected over the rib cage through the scapula, so it does follow this plane of the scapular movement. So as the scapula moves on top of the rib cage, depending on how the person is positioned, if they're rounded or if they're standing more erect, then it's going to dictate what happens with that plane movement. But ultimately, the AC joint has very minimal movement, so we don't tend to focus on the kinematics much, and as you do joint mobilizations or joint play, it's hard to manipulate certain factors in here, so you don't have to worry about that too much. We're going to focus much more on the glenohumeral and scapulothoracic movements. Oh, what's on this next slide? That's weird. Now, I'm not sure how this got in there, but there's a brown chicken and a brown cow. You know, I would just say, brown chicken, brown cow. Okay, there you go. If you don't like that, we'll just go to the next slide. Okay, summary of scapular motions. And this is something that really helps if you just hold your hands as the scapulas would be, and then you start to move them around different directions and just say what those movements are. And so you can see if I bring them in like this, it's more that internal external rotation versus an upward downward rotation. And then when you're moving in this axis point, it's more that anterior and posterior tilting. One of the main motions that we look at externally when we're looking at a patient, a client, an athlete, someone like that, and we see that medial border, that vertebral border of the scapula kind of bring out like that, that internal rotation is typically not how we describe it. We describe it with the term scapular winging. And then we'll talk about which muscles may be weak and which nerves supplying those muscles may also be compressed or compromised. But oftentimes in children, you can see this motion. You can see that their scapulas aren't completely set on that area. So there's some winging. One of the tests we do is just looking at overhead motion, or we have them push protraction, and you can see with that stability that's not there, the scapula, the medial border starts to wing out, but really that's called internal rotation of the scapula. So that's just a good summary. One of the exercises you may have seen done, this video isn't allowing me to play for some reason, but we'll show this in class, is this dynamic hug exercise. So you have a TheraBand. He's holding the TheraBand in each hand, and it's secured to this rod right here, and they're doing that hugging type exercise. So that is resistance into the protraction or the reaching forward motion. As you look at the scapula here and what it's doing, the scapula is obviously going to dictate what happens to the acromion. So as we protract, the acromion is going to follow the shape of the rib cage, and it's going to come around the side into that motion. We're going to call that an internal or an external rotation. So if they're protracting, they're internally rotating. If they're retracting, they're externally rotating. Not of the glenohumeral joint necessarily, but of the acromion. So here you have just another picture of that. So this is a superior view. Almost imagine an aerial view of the right shoulder. As you do a protraction and retraction, you can see there's this internal and external rotation, and that internal rotation would be more like a winging motion. There's a natural amount of that that's supposed to occur in all of us, but it can be more pronounced in certain individuals. Generally, there's very minimal movement here, so we're only estimating about 30 degrees or so. 30 degrees of internal, external, total range of motion, so much less than some of the glenohumeral or scapulothoracic movements we're going to be looking into. The other direction that the AC joint's going to do is this anterior and posterior tilting. So if you can imagine, your hand represents the scapula, with your fingertips here, middle finger maybe, representing the acromion. As I go anterior or posterior, I'm going to judge this movement on where the acromion is going, not necessarily where the inferior angle is going. So as that acromion goes anterior, it's going to be an anterior tilt. As that acromion goes posterior, it's going to be a posterior tilt. So anterior tilt, posterior tilt is going to occur there. My only suggestion is don't necessarily pay attention to the inferior angle as naming that. Just name it on where the acromion goes, and realize it's not in a straight axis point because of the shape of the scapula. It's going to be angled slightly, but that's why it's often coupled with an internal and external rotation of the acromion or the scapula. This is your anterior and posterior tilting. Another primary movement that's going to occur, especially as we do abduction, scaption, reaching overhead, that scapula has to position itself to allow the glenoid to move to help the humerus. So as that glenoid comes upward, the lateral border is also going to move upward, and it's going to move upward. So you're going to get this upward rotation, swing around, and if you look at someone else from behind and you look at their scapula as they move upwards, you're going to see that inferior angle moves laterally. That's going to position the glenoid to be in a point where it can accept the load of the humerus. So you're going to get that upward rotation, but that's going to make the inferior angle move laterally away from the vertebrae. Now on this point, there are some times that you do this isolated upward rotation, but generally speaking, there's this composite series of movements that occurs, and there is this tension in the coracoclavicular ligaments that's going to inhibit that further as well. And coming up to the last slide, one thing that we talk about and we have patients that experience are some type of AC joint dislocations or shoulder separations. So with this, you can see the various types. There's actually more types than this, but this is a good summary of the initial types. And these really are ligamentous sprains. So we talk about AC ligament sprains. So you can see on type 1 and type 2, looking at this superior AC ligament as being involved. So that's obviously less of a trauma, and this would be type 2, a complete separation, and then in this case you have the separation, also you have the displacement of that acromion, and in order for that to occur, you have involvement here of the trapezoid and conoid ligaments. And so you have 3 ligaments essentially that are torn, or you could say 2 ligaments because the trapezoid and conoid ligaments are really one combined ligament, but you have multiple structures that are involved. And for people that have had this, if they don't have surgical repair, you'll often notice that they have that deformity. So when you're looking at them in observation, you may see that their clavicle looks to be positioned higher, so it almost looks like it's pointed in a certain position or direction. And you could see some other pictures of other types of AC joint dislocations here. And that's this lecture. For the next one, we'll go over the scapulothoracic joint mechanics.